Hello everyone. In this video I'm going to be discussing the medications for COPD, congestive obstructive pulmonary disease, which is an umbrella over infections and diseases such as asthma, chronic bronchitis, and emphysema. For asthma, there's three main pharmacologic classes. We've got our anti-inflammatory agents, our mast cell stabilizers, and our bronchodilators. Our anti-inflammatory agents would be our glucocorticoids, which is prednisone, most effective anti-asthma drugs available because it just goes in and opens up the passages so that people can breathe. And then our mast cell stabilizer, what does it do? It stabilizes the cell membrane where the antigen-antibody reaction is taking place, preventing that release of histamine, histamine is driving the constriction, is causing that bronchoconstriction. So again, prednisone's for inflammation, mast cell stabilizer to halt that antigen-antibody reaction, and then our bronchodilators, which are going to dilate and open up the bronchioles and bronchus. We have our beta-2 agonists, which is going to be albuterol, which either comes with names of Proventil or Ventolin, very short acting, and these are really the ones, the inhalers that everybody has at home. And then we have our long-acting ones are from the Motorol family. R4 Motorol is Brovana and 4-Motorol. So glucocorticoids, again, suppress inflammation, promote synthesis of bronchial beta-2 receptors, and increase their responsiveness to the beta-2 agonists. Inhales and systemic glucocorticoids are used for long-term prophylaxis of asthma. So they may be on these for a long time. Usually these are given on a routine basis, not PRN, unless the attack is severe, then they'll give inhalation. So inhalation drug therapy, three obvious advantages. The therapeutic effects are enhanced because we're putting it right down in there. We're not, giving them a pill to swallow or giving them something IV. Systemic effects are minimized because it's going right to the lung. And relief of acute attacks is rapid. It's immediate. There's three types of inhalation. Our metered dose inhalers, and they're called MDIs, our dry powder inhalers, or PDIs, and our nebulizers. We're always going to take the beta stimulator first before the glucocorticoid. We're going to take this inhaler before the steroid. And for obvious reasons, we need to open that up. The action's immediate. We have to open the respiratory passages up so they do not have a respiratory arrest. And then the steroid will maintain stability with the anti-inflammation. But because it's coming later, we always have to do the inhalation first. Our B2 adrenergic agonists or our bronchodilators, that's what those mean. A B2, beta-2 adrenergic agonist is a bronchodilator. It promotes dilation, relieving bronchospasm. Also, the beta-2 drugs, agonists, suppress histamine release in the lungs and increase ciliary motility. They're given orally or by inhalation. Oral is long-acting. Inhalation is somewhat short, and some of them are long. A short action begins immediately. It peaks in 30 to 60 minutes and lasts 3 to 5 hours, so very, very good coverage. Can't be used for long prophylaxis. B1 adrenergic receptors, because we're going to talk a lot about that when we talk about the heart. They're located in the heart. The B2 adrenergic receptors are located in the smooth muscle of the bronchioles, arterioles, and visceral organs. An example of a B2 adrenergic agonist response results in bronchial, gastrointestinal, and uterine smooth muscle relaxation because those are visceral organs that have smooth muscle in them. Glycogenolysis, or breakdown of glycogen, and cardiac stimulation. Beta-2 adrenergic agonists are synonymous with bronchodilators, and it's so much easier to say bronchodilators because we know we're dilating the bronchus and the bronchioles. However, you need to know that they are, the pharmacological term is going to be a beta-2 adrenergic agonist. That's why I'm telling you that it's involved in smooth muscle and where it's located. Most effective drugs for relief of acute bronchospasm and prevention of exercise-induced bronchospasm. Also used for bronchitis, emphysema, bronchiectasis, or other reversible airway obstructions, because we know what it's doing. It's dilating the bronchus. So our bronchodilators are B2 adrenergic agonists used in asthma for quick relief, long-term control. Adverse effects are always going to be tachycardia, angina, and tremor. And why does a spacer help? What do you suppose that is? We have oral preparations. Too much is going to cause angina, tachydysrhythmias, and tremors, because all of these are going to speed up the heart. So it helps because a spacer builds up the pressure so that the drug goes farther into the lung field. So a spacer is an apparatus that we put on an inhaler, and it gives power to the inhaler. And so again, it builds up the pressure in the apparatus that we're giving the drug in, so that it goes much further down into the lung fields. And that's what a spacer is all about. Inhaled glucocorticoids. It's the most effective anti-asthma drug available. Adverse effects, sometimes they can get a yeast infection called oropharyngeal candidiasis, and that means just the mouth and the throat. And then dysphonia is kind of a funny name, difficulty with your voice, so it can change your voice a little bit. Interventions: gargle after each administration with water, and using a spacer is very good with all of this because we know we're going to cover more territory. Side effects of oral and IV steroids is going to be a peptic ulcer, osteoporosis. Some other normal steroidal side effects would be diabetes, high blood sugar. So steroids do have really strong adverse effects and side effects. But, if you need it for inflammation to keep the airways open, we have to have people breathing. Oh, I forgot to tell you this. Glucocorticoids can slow the growth of children, but does not affect adult height. It slows it, but it doesn't stunt it like some drugs do. So it will slow it down, but they can catch up later. And then to look at our mast cell stabilizers, and we know what that does. It goes in and stabilizes that mast cell, the reaction of the antigen antibody at the plasma membrane. We have cromolyn, which is a very common one. Intel, prophylaxis of asthma, helps with exercise-induced asthma, meaning they're actually fine most of the time, but when they exercise and their heart starts beating fast, it can induce an asthma attack. It suppresses inflammation. It's not a bronchodilator, because it's a mast cell stabilizer, but in stabilizing that mast cell membrane, it does suppress inflammation. Route is always going to be inhalation, nebulizer, and again, metered dose inhaler. These are just different ways to give it. Adverse effects: it's the safest of all anti-asthma medications, but you can have a cough or a bronchospasm. Always have the patient start with the lowest possible dose. Encourage the patient to monitor their peak flow meter volume to make sure it's working. And then we'll move on to our methylxanthines, which are bronchodilators, used mainly with the acute patient only if they have not responded well to other drugs. Theophylline, aminophylline are the two most common ones that we use. The pharmacologic properties are identical. You can see by the PHY-LLINE, same family. Very narrow therapeutic index, so we need to watch this one closely. We have to maintain a plasma level of 10 to 20 micrograms per cc. This I want you to know. This is important. There is toxicity to it. Routes, a lot of times theophylline is given PO. IV is usually in the acute state, and that would be aminophylline. Drug drip rate must be monitored closely because of that narrow therapeutic index, because we know it can cause tachycardia. And so if we have aminophylline to the point where, say we started under 10 in that plasma level, the therapeutic index, but now we're at 24, the patient, we can really hurt their heart. So if theophylline's not working, the patient needs to be transferred to ICU, put on a mechanical ventilator with a heart monitor. Safety, patient teaching: caffeine is a methylxanthine, can intensify the effects of theophylline on the central nervous system and the heart. So just a side note here, bronchodilation is not effective when it is being inhaled. PO is for maintenance therapy. With regular use, these oral drugs can decrease the frequency and severity of asthma attacks. Aminophylline is preferred for IV use, highly soluble. Have to give this med very, very, very slowly. no faster than 25 milligrams a minute. Rapid injection can produce severe hypotension leading to death, and it's also incompatible with a lot of other drugs, so it has to have a line of its own. And then we have our leukotriene modifiers, and this suppresses the effects of leukotrienes, which decreases inflammation, bronchoconstriction, edema, mucus secretion, and recruitment of eosinophils and the inflammatory cells. So again, suppresses the effects of leukotrienes, which decreases inflammation, bronchoconstriction, edema, mucus secretion, and recruitment of eosinophils and inflammatory cells. And you can see all of these here. Zyflo, Accolate, Singulair. Zyflo, leukotriene synthesis inhibitor. Accolate's a leukotriene antagonist, so it's not going to let it work. And Singulair is the same thing. These are all used to stop inflammation. Singulair is used more for maintenance, and Zyflo is used for prophylaxis. It antagonizes or stops that inflammatory process. So treatment of COPD, methylxanthines are bronchodilators such as theophylline, inhaled or oral steroids, which are glucocorticoids, anticholinergic drugs improve lung function by blocking muscarinic receptors in the bronchi, causing bronchial dilation, mainly used for COPD, and then home oxygen. Treatment of COPD, our anticholinergic drugs would be Atrovent and Spirivia. Atrovent's an atropine derivative administered by inhalation to relieve bronchospasm. Mucoristic antagonist, meaning it's going to antagonize mucus. Therapeutic effects begin 30 seconds, reaching 50% of the maximum in 3 minutes and lasting for 6 hours, so that's a good deal. Can cause dry mouth and irritation of the throat. And then Spiriva is longer acting, maintenance of bronchospasm associated with COPD. Again, same family. Therapeutic effect begins 30 minutes after inhalation, and this is a peak in 3 hours, but it lasts 24 hours, so it's probably a little bit better. With subsequent doses, bronchodilation gets better and better, so by 8 days, patients should feel better. Very dry mouth, so that we suggest that they suck on sugarless candy. Okay, so that's the end of the meds for COPD. Not too bad, huh? Alrighty, well, bring your questions to class, and we'll definitely try to go over these on Tuesday of this next week. Would be October 7th, 8th, 9th, the 10th. Okay, see you in class.